Welcome to the Alabama Public Health Training Network. I'm Beth Allen, Nurse Practitioner Director and Women's Health Director with the Alabama Department of Public Health. Thank you so much for joining us for our program today. It's titled Striving for Excellence in Women's Health. If you have a question about anything that's being discussed, call or email during our broadcast. The phone number and email address are on your screen now and will appear later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses, social workers, and nurse practitioners for this program. In order to receive credit for this training, you must watch the entire program and then complete and return the sign-in sheet and evaluation. CE credit awarded for this program will not expire. Before we get started, I just would like to introduce Dr. Grace Thomas. Dr. Thomas is our collaborating physician and has been our guider and leader for many years throughout Alabama Department of Public Health. She is our Family of Health Services Medical Officer and Bureau Director, and she would like to kick us off with a welcome, and we thank y'all for being here today.
Good morning, everyone, and welcome to our annual Nurse Practitioner Conference. It's actually our 16th conference. Obviously, this conference is somewhat different and quite abbreviated, but such are the times. Nevertheless, it's good to be in the same virtual space with you, and I'm grateful that we are able to do this in spite of COVID. I'd like to welcome two new nurse practitioners to the Northeastern District, and those nurse practitioners are Sarah Stone, who I think is based in St. Clair. Please forgive me if I don't remember that correctly, and Nicole Fuller, who is in Shelby County. We're delighted to have them as part of the ADPH frontline workers, and we hope that their tenure with us is long and fulfilling. So as Beth mentioned in the introduction, for as long as I can remember, the slogan, if you will, for this conference has always been striving for excellence. And so part of historically what we've done is a half a day. I think we went from 2 days initially, then to a day and a half. But a half a day would be spent sort of looking like a bit of self-reflection, if you will, and sort of taking stock of things, not only things that we didn't quite get right, but things that we've also done well, so that we can better serve our population. So in today's presentation, you'll hear an update from our panelists on the Well Woman program, which is part of a larger thrust, if you will. It's part of a larger effort and push to, and this Well Woman piece aligns with our greater initiative, which is the Maternal Child Health Block Grant, and it's probably more details than you guys need or want to know, but it is important, and it's an evidence-based measure, and it's part of a national strategic measure, and one of the things that Alabama is striving to achieve. But it's to place Alabama women in optimum health, not just before their pregnancies, during their pregnancies and after their pregnancies. So it's over their entire life course perspective, and not just that snippet of when they're pregnant. So it's a vital program that aligns with our overall plan to make our state, the women and families in our state, healthier. The remainder of today's program will focus on our continuing efforts to combat cervical cancer in our state. So although as a state, we've done fairly well in terms of screening for cervical cancer, you'll hear some very sobering statistics today about cancer, cervical cancer in Alabama. The cervical cancer that is very treatable when caught early and almost invariably fatal when it's caught late. The NP seniors have done they've done a great job in pulling these presentations together, which will focus on the nuts and bolts of colposcopy and just documentation. Kind of, I think one of the talks is titled A to Z, PAP and colposcopy A to Z. So we kind of really get into the weeds a bit, which I think is important. And the emphasis, though, is always with QI, quality improvement and assurance, in mind. So that's kind of the basis for this sort of housekeeping, where we look at what we're doing internally. So I commend their efforts for all this hard work. I think I would be remiss if I didn't also commend the Women's Health Division, which is headed up and led under the directorship of Beth Allen. This division's efforts, whether it's the CHA grant, and you guys may not be familiar with all of this, but how it trickles down to the health department is that this grant, which is a supplemental grant to, or an additional grant, part of Title X, allows us to offer HPV vaccination across the state. So we've got folks in the central office who, under the directive of Beth and Jessica Hardy and got Nikki Kiefer. I don't want to go down this trail. And Lori Gregory. I start naming names and I get into trouble. But these folks have worked to put forth these programs and get additional funding so that we can do things throughout the state to improve the well-being of the women in our state and families in our state. The additional piece is telehealth and the expansion of that. And I'll talk a little bit more about that, but that's part of all these efforts that sort of undergird, they support many of the strides that we've made in implementing services, whether they're colposcopy services or telehealth, telehealth services. I think another milestone that I need to mention that was spearheaded by Beth is the collaborative practice exception through the Alabama Board of Nursing that has allowed our nurse practitioners who are not traditionally trained in women's health to be seamlessly trained in IUD insertions and implant insertions. In addition, this is the exception that has given us permission to implement colposcopy. These are the things that we're doing here in spite of COVID. I think that has sort of helped to keep our wheels on the track, if you will. I also want to give, as we're talking about the Women's Health Division, a quick nod to Thelma McDade. Many of you have been, have seen the colposcopy clinic. Some of you have helped tremendously with getting the colpo clinic going, but it's a lot of work to get to the county health departments. And so Thelma is the kind of behind the scenes person who puts all of the instruments, from buying them to getting them sharpened to keeping track of them, and God knows what. I don't know what all else she does, but it's part of the machinery that keeps the program running. So I'm truly grateful for that. And then one other thing I just want to mention in terms of the Women's Health Division is to just give a nod also to Dr. Jessica Hardy and her efforts to use our colposcopic data through an agreement that's kind of now, it's fledgling. It's sort of now getting off the ground with the National Institute of Health. So stay tuned for that. I mean, I think it's certainly going to give us the ability to look at what we're doing and the impact of colposcopy by having the folks at the NIH analyze our data. So we're really excited about that, and we've had a couple of meetings with them, and it's truly exciting that that we're able to make these inroads. And as you guys are aware, you know, this is one of the fastest growing areas in terms of pap smears and just the whole technology behind the management of abnormal pap smears. I also want to thank my colleagues, Doctors Maxwell and Gillum. Without them, none of this would be possible. They do a lot more, much more than just take call and answer consults. Dr. Gillum, as you know, oversees the IUD project, which has just been phenomenal across our state, and again allows us to access and to provide access to our women across the state. And Dr. Maxwell, as you guys are aware, heads up the Well Woman program, and all, you know, these guys also have helped tremendously with the COVID effort, as have all the staff here. So I am truly blessed in that regard, and each one of these guys has a true public servant's heart, and I feel immeasurably blessed to have the opportunity to work and to team up with them. So to say that COVID has, upended our lives, I think is an understatement. It has also laid bare health inequities, social injustices, heightened political and racial tensions. But, you know, I think there has been a silver lining for public health, and that is that we have, there has been a shoring up, if you will, of our infrastructure, so that districts have what are now called strike teams, you know, and they've got an epidemiologist that's assigned to each district. But specifically in terms of family planning, we got, I guess, a shot in the arm via telehealth, which allowed us and allowed you, thanks to your tenacity and Beth chasing the Alabama Medicaid folks, so that we are at a point right now where these services are going to be permanently expanded. So the details about all of that will follow. But I think that is a great thing to be able to couple what we're doing in in-person visits and also have the telehealth arm. So we're truly excited about that. So I feel as though with the return of, you know, whether it's gradual in some places, and, you know, we do things very differently here and across the state, you know, to in-person services coupled with the permanent expansion of telehealth, and our IUD training and you know, colposcopic training, ramping those things up in the form of a train-to-trainer type thing. I think we are, I think ADPH is poised. I think we're ready, you know, to continue to provide unparalleled access, if you will, to those who are in our communities who are underserved and unserved. So So I'm glad that we were able to do this. Thank you for everything that you do, and thank you for your attention today. And with that, I'll turn it over back to Beth.
Thank you so much, Dr. Thomas. Couldn't be said better, and really appreciate your support. We couldn't do it without you, and that should be said as well. So I would like to merge now into our first presenters, and I am excited to have both Dr. Joseph Reitmeyer and Sabrina Horn, nurse coordinator over our Well Woman program. Sabrina brings over 20 years of nursing experience into this role, and she is phenomenal. And we have just had a really opportune time through MCH and initiatives that they have to grow this program. It is hitting a growth spurt as well. So we're very excited for the updates that they're going to bring. Dr. Joseph Reitmeyer is a nurse practitioner that has been with us for very many years, has served through Montgomery County Health Department and the East Central District. He is a leader, and we appreciate you both, and I'm going to turn it over to you.
Well, good morning, everybody. I would like to share some information about the Well Woman program. A question that I hear quite often is, what is Well Woman? Well, Well Woman is a program of ADPH that creates the opportunity for women ages 15 to 55 to receive preventive health screenings and management of chronic diseases. The program is an evidence-based program that utilizes the New Leaf module. The New Leaf is a module that was developed at the University of North Carolina at Chapel Hill. New Leaf is a scientific-based intervention tool that emphasizes practical strategies for making changes in dietary and physical activity behaviors. The goal of the program is to provide preconception and interconception care, as Dr. Thomas referenced, for the women of Alabama of childbearing ages as a foundation for wellness, identification of chronic diseases, and planning to adopt a healthier lifestyle. The program started in 2017 as a pilot program in Wilcox, Butler, Dallas, and we have continued to expand. In October 2018, ADPH received funds from the Governor's Initiative to Decrease Infant Mortality. With the federal funding of the Governor's Initiative, we were able to expand to 3 new counties in East Central District: Macon, Montgomery, and Russell. The program is currently in 6 counties: Butler, Dallas, Macon, Montgomery, and Russell. The program has been fortunate enough to expand to Marengo County during this fiscal year, but unfortunately, due to COVID and other staffing issues, the program has not started in Marengo County yet. In this fiscal year, we have plans to implement the program in Henry and Barber counties. We are also having conversation about growing to 3 or 4 more counties in the future, which would be represented on the map. There are 5 components of a Well Woman visit. We have family and individual health, which the RN gathers individual health and family history on the initial visit. We have the clinical assessment, which are the lab and diagnostic testing. Sorry, I thought they were controlling the slides. I'm so sorry. So I will briefly begin again. Thank you, Joe. As I referenced, a question that I often hear is, what is Well Woman? And it is a program that offers preventative health screenings to women ages 15 to 55. We utilize the New Leaf module, which was originated at the University of North Carolina at Chapel Hill. The map there represents our counties that we're currently in and counties that are pending. Currently, we're in 6 counties. We're in Butler, Dallas, Macon, Montgomery, Russell, and Wilcox. Soon, we will be in Marengo County, as I referenced. Due to COVID and staffing issues, we haven't been able to implement the program there in Marengo, but we did the training for staff lab equipment training. So we're on our way to Marengo County soon. Henry and Barber, we're having conversations to grow there, and other counties as represented on the map. Components of the Well Woman visit consist of family and individual health history, which the RN completes on that initial visit. We have clinical assessment, where the labs are performed by the clinical aide. The physical exam is done by the RN and the MP. The MP completes the risk assessment counseling, which consists of reviewing the labs, disease management if needed, and risk reduction counseling to educate that client on ways to adopt a healthier lifestyle. And also she's referred to the social worker after the MP for risk reduction counseling, which consists of helping her to develop that healthy life plan and any needed referrals for community services. Our current show rate is about 50% in each county. Each county has a designated day which they offer Well Woman services. Our enrollment has been quite productive. In 2019, we enrolled 479 participants in all 6 counties. In 2020, we did have a decrease. Our total enrollment was 371 in all 6 counties. Like other programs, we have experienced a decrease due to COVID. The average age of our participants is about 35 years old at the current time. The youngest participant that we have enrolled is 17 years old. And 95% of our clients are African Americans. While our visits were postponed in March of 2020 due to COVID, in August of 2020 we resumed. We resumed with some new implementations. Our leader, Dr. Maxwell, she initiated telehealth visits into our program. The visits consist of the MP conducting a phone call to the client to complete her risk reduction assessment. As I mentioned previously, the MP completes the risk reduction counseling, which consists of reviewing her labs, treating her for any chronic diseases, or even educating her on ways to adopt a healthier lifestyle. I have invited Mr. Joe Reitmeyer, who is a highly skilled nurse practitioner, to go into detail a little more about the telehealth visits for Well Woman. Joe has taken the initiative to create a template for the nurse practitioners in East Central District for the telehealth visit.
I'll let you do the slides for me. I want to start out by saying I realize that not all practitioners across the state at this point are doing Well Woman, but that doesn't mean you might be down the road. So this is good information for you to have as far as getting the basics, especially for some of our newer practitioners. There's a video online where Dr. Maxwell had our initial training as far as hypertension and treatment of hypertension. Also, the written protocols for Well Woman are available as well, and I would encourage everyone to look those over if you haven't done so already. And with those out there to your, to be able to be reviewed by yourself, I'm not going to go into a lot of details with that type of thing. But I do want to mention the basics. Basically, Well Woman is funded, and if you're, doing your monthly charges, it's funded under reducing infant mortality. And as such, those who are eligible are women that are fertile. In other words, if you have a 30-year-old that comes in and certainly could use the Well Woman services, but has had a tubal, she would not be eligible. And that's something to bear in mind. The second requirement is they must live in the county where the services are being offered. I'm not real fond of that requirement because in East Central District we've gone to a hub and spoke system. So most of our exams are done out of Montgomery County or Lee County or Tallapoosa County. And of course we see a lot of women from other counties that can certainly use these services. But without that address in that local county, they're not able to obtain the services at the moment. So those are the basics as far as who's eligible. The NP visit it's kind of broken down into 3 different categories as far as how quick do they need to see the NP. Now, some of our counties, Macon County in particular, very often they'll do the NP visit the same day they do the initial nursing visit. That's not absolutely required, but that's just the way that they've been doing it. But the first category would be alert values. Now, those are values where the cholesterol is so high or the blood pressure is so high that those patients need almost immediate attention. And the NP needs to see those patients within 7 days. Now, is that a patient that's a good patient for telemedicine? Probably not. In other words, that patient probably needs to come in the building and be seen. In fact, I would go as far as to say, absolutely, bring them in the building and see them. And that needs to be done within the first 7 days. The next category would be disease level values. And with that category, and these values are all listed in the literature I'm talking about, the NP visit needs to be within 30 days if that patient's not already being treated. Now, if they're already being treated, then it doesn't have to be in the 30 days. But if they're not being treated, it needs to be in the first 30 days. To me, that's the breaking point. If they're not being treated and their disease level values or alert values, you need to see them in person. 7 days for the alert, then 30 days for disease level. Now, if they're being treated or if they have normal values, which is actually the majority of our patients currently, those are the ones that I think would be okay to do telehealth visits with. So I've created this template, which basically have a cheat sheet that when I make a phone call to those patients, and telehealth with Well Woman is quite a bit different than telehealth with family planning. Because with family planning, that patient's sitting out in the parking lot, waiting on their depot or waiting on their pills or whatever. With telehealth with Well Woman, you're basically calling them at home. And you may get them and you may not. Some patients will see a number they don't recognize and they're not going to answer it. So what I do is I make the call and my social worker will give me a list of patients that need to be followed up with, that it's been 6 or 90 days or more, and that's how long you have for everybody else is 90 days. And we'll start going through that list, making these calls, and if we get somebody on the phone, then this is the template we go through to get information. Once we have that information, that's when I actually schedule the visit. In other words, I don't even put them in the computer until I've already talked to them, because otherwise there wasn't any point in scheduling a visit because you couldn't get a hold of them. So we schedule a visit, put them in as a Well Woman revisit, and do our documentation. And like I said before, the only ones I feel like that I'm comfortable with doing televisit with are the normal values or the disease level values already being treated. Okay. All right. One thing I do want to point out as well is with the alert values and the disease level values, occasionally you might get a patient that doesn't have a primary, and she needs treatment pretty quick. All Well Woman counties are supposed to keep some Klonopin in stock as far as immediate treatment, and then we have the ability to write prescriptions for hypertensive drugs. If you need to do that, I would recommend a consult to do it, just simply because we don't do a lot of it. And it's always nice to have those extra consults anyway. We're always looking for a consult to keep our once a week up. So I would recommend if you're having to actually write a prescription for some hypertension meds to go on and do the consult. But at the same time, this program is not designed, we don't want to be their primary. In other words, we're more of an adjunct for their health and some of the things we offer to improve their health to their primary physician. So if you're having to write a prescription for a hypertensive drug because they don't have a primary and they haven't been treated, along with that, you need to be doing a referral to a primary. They need to get in with a primary. Okay. The next slide is basically And it's actually two different slides. It's how we end up, how my documentation looks after I've done a telemedicine visit. And it's not real easy to see, but if anyone wants a better copy of that, I can email it to them. If they just contact me through email and say I'd like a better example of the documentation. The only thing I do want to point out with my documentation, some of the verbiage is the same that we do with the telemedicine for family planning, as far as, you know, being a telemedicine visit due to COVID and different things like that. So a lot of the verbiage in the HPI is the same. The other thing I always like to put in my documentation is I pull over from the tree that baseline 2 that's got all their lab values. Because one of the things we really want to be concerned about is that risk percentage. And that's something we have to look at as far as what kind of treatment they need. And that's all kind of laid out in the documentation as far as the program. But if you want a copy of this documentation, we'd be glad to send it to you so you can kind of look and see exactly how we're documenting the well woman televisits. I think the next slide is the other half of that. And that's the basics as far as doing a well woman visit. Now, the nurse practitioner part of this, and this whole program currently is more social worker and nurse driven. Our part is more just to do the risk counseling reduction. So we're doing more counseling than we are exams. Truth is, when I go in the room with a visit that they're right there in the building, about the only thing I'm doing as far as the exam parts, listening to their heart and lungs, and then more so just counseling, talking to them. So our part's a lot different than what we're used to doing as far as family planning, where we're primarily doing that more extensive exam. So that part's a little bit different. All right, and then after you've done the NP visit, it's up to the practitioner to determine how soon you need to see them again. Obviously, if they're alert values, you may bring them back in 30 days. You've got to make that clinical judgment. How soon does this patient need to get back in here for us to take another look at them? The ones that are basically normal values, it may be fine to see them in a year. But that's something that's a judgment call based on your evaluation of their current lab values and overall health. I think that's covers most of what I had.
All right. Well, do we have any questions, comments?
Sabrina, I have a question. I wondered what and you may not have this number readily, in terms of our social workers assisting with getting our patients in with the primary care, with a primary care physician. How successful are we at doing that?
When you mention it, I think of Russell County specifically. I would say we are 30 to 50% there. There's a new clinic that they have in Russell County that they see lower income clients, and I see a lot of documentation where the social worker there refers them to that healthcare center. I'm not sure about Montgomery County, whether we refer them here, but I do see quite a few referrals there in that area of Russell.
I think it would be by location a lot. Montgomery County has the benefit of having HSI, which has a lot of locations, and they're not free, but they're income based, and they generally take all of our referrals. And other counties don't have as good of services. Lowndes County's actually got an HSI location, but Macon County might be a little tougher sometimes to get in with the primary. And it may be that some of those counties that are out there and smaller, they may have to actually come to a larger county to find a primary. I think it's trickier when you're in a small rural county than it is a larger county.
And just to piggyback on that, what Joe referenced, the county location makes a bigger difference. Because I don't see many in the Dallas County area as well, but Wilcox and Butler, there's not a federal services for those with low income, so it's kind of stagnant as far as where to refer them to. So
It's the same thing with some of the program services. Like a lot of our clients are interested in the program itself because there's perks, like a free gym membership. Not every county's got a gym. You know, I mean, and I'm not going to drive all the way from Union Springs up to Montgomery to go to the gym every other day. I mean, so that's tougher for those counties in terms of being able to take advantage of some of the perks with the program.
but we do offer physical activity in each county that we're in. We've partnered with a community-based facility in each area to offer those services to women in each county. So
Some of the other things we didn't mention as far as perks are nutritional classes. If they're hypertensive, they can get a free electronic cuff to check their own pressures, and we encourage the blood pressure logs so the primary would know whether they need to adjust the medications. Counseling as far as from both the social worker and the nurse practitioner. I generally, especially the morbidly obese patients, I encourage, low impact exercising. I always tell them I don't expect them to go out there and run a marathon. That's actually hard on the knees and hips if you're way overweight. And I like the, walking, water aerobics, swimming, things that are more low impact as far as weight loss.
Well, thank you both. I don't see any other questions at this time, but there may be some that we receive via email, and so I will certainly get with you. I much appreciate this presentation, and I am really excited about the growth of Well Woman to meet the needs of our patients. Most nurse practitioners know and see on a daily basis the need for hypertension treatment, and this is just an asset to be able to offer in the counties that we're building this to. So thank you both very much for your time today and your presentation. We appreciate that.
thank you for your attention.
At this time, we're going to merge into our presentations through our nurse practitioner seniors. So I would like to go ahead and introduce the first two presenters that you will see. Presenter number one is Stephanie Phillips, and Stephanie Phillips is a nurse practitioner senior that serves the north part of our state. And in addition to that, second will be Dewana Tatum, and Dewana serves basically the south part of the state. As you know, we have 4 nurse practitioner seniors currently, and they pretty much quarter the state. So I appreciate everything that they do, and I will let them introduce their topics, and we're very excited to bring this material to you today. As you know, it has been a work in progress, but we are moving towards training for colposcopy. So here we go. Stephanie?
Hi, today I'm going to be talking to you about cervical cancer and what we as healthcare providers in the health departments can do to help with this problem in our state. The objective of this talk today is to be able to discuss the warning signs of cervical cancer and our role in prevention. As healthcare providers in Alabama, we're in within the health department, we're in a pivotal position to make a positive impact on the incidence, morbidity, and mortality of cervical cancer affecting the women of our state. However, if we don't understand the problem, it makes it hard for us to understand how we can actually make a difference. Worldwide, there are over 500,000 new cases of cervical cancer yearly, with over 300,000 deaths. In the United States, there's over 14,000 new cases annually with over 4,200 deaths. This figures into a rate of about 7.5 new cases annually for every 100,000 women in the United States. Now, this is Alabama. Alabama, there is an estimated 238 new cases each year at a rate of 9.6 new cases annually for every 100,000 women. Alabama is above the national rate. If you remember, the United States was 7.2, and so Alabama is above the national rate. We actually rank 3rd in the nation for the highest rate of new cervical cancers. And our incidence rate is actually increasing. In 2013, between 2013 and 2017, we were 4th, and now we're 3rd. This is not football. And War Eagle, Roll Tide, whatever you cheer, it's not football, and we do not want to be number one. We're moving in the wrong direction. Cervical cancer was once a leading cause of death for the women in the United States, and now it is one of the most preventable cancers, so women should not be dying from this cancer. Our rates and our numbers are close to that of a third world country. Once we have a clear understanding of the problem, we can begin to understand the significance of screening our patients. We screen our patients with pap smears, but there's so much more than just doing a pap when it comes to screening for cervical cancer. The goal of screening is to prevent morbidity and mortality related to cervical cancer. However, 60% of all cervical cancers are seen in women who are never screened or have not been screened in the last 5 years. Usually we see these patients when they develop a problem, whether it's bleeding, pain, or discharge. If you see a patient who hasn't been screened in greater than 5 years or never screened, that should kind of pique your interest, and you should put them on your radar to be sure and go back and check their results when they come in. Cervical cancer is rarely visible to the naked eye, so I'm going to go over some of the symptoms that you may see a patient present with when they come to the health department. The primary presenting symptom when a patient has cervical cancer is some type of bleeding. It's reported in 2 out of every 3 women with cervical cancer. And the bleeding may be postmenopausal, abnormal uterine bleeding, postcoital bleeding. Other symptoms that you may see are vaginal discharge, odor, or pain. Assessment of any patient starts with a good history, but it's especially true in a patient who hasn't been to a provider in a long time or they present with a problem. So when you're performing an exam on a patient who has a problem who hasn't been seen, be sure to do a careful speculum exam, a thorough and careful bimanual exam, and a rectovaginal exam if it's indicated. When you're looking at a cervix of a woman who has cervical cancer, the cervix may appear nodular. You may see areas of ulceration. There may be necrotic areas. You may see a white plaque known as leukoplakia. The cervix may be very friable, and when you touch it with the brush, the spatula, the speculum, it bleeds very easily. On bimanual exam, the cervix may feel large. It may be firm. It may be barrel-shaped, or it may be fixed and in place and not movable. This is a leukoplakia. This is a patient that we saw in a colposcopy clinic in Coleman. She was a 29-year-old who had an abnormal or high-grade PAP in 2015. She had a high-grade colposcopy that same year and a high-grade loop with positive margins in July of 2015. She came back to colposcopy because in 2020 she had a low-grade HPV positive PAP. And this was the appearance of the cervix upon insertion of the speculum and before any acetic acid was applied. Leukoplakia does not always mean that there's cervical dysplasia. However, if it's intermixed with areas of hemorrhage, it should be extremely worrisome to you as a provider. These are some other pictures of cervical cancer. The picture on the left, you can see at 3 o'clock there's necrotic areas and the cervix appears very nodular. The picture on the right is a nodular red friable lesion. You know, the cervix bled very easily when you touched it. These are just some more pictures. On the left is an exophytic lesion. The mass appears to be growing out of the cervix. I've seen one frank cervical cancer since I've started with the health department, and it was about a year and a half into me starting. It was in a 40-year-old lady who had not had a pap smear in over 15 years, and the mass appeared like this one on the left. And I sat there and looked at it, and is this really what I'm seeing? It took me a while to convince myself that, yes, this lady had cervical cancer and this was a mass. And then the picture on the left is just an ulcerated lesion on the cervix. The picture on the right. Why are these warning signs so important? Every cervical cancer is not going to just jump out at you. A lot of them are very subtle. If you look at the picture, can you tell that this cervix has cancer? No, not just by looking. She was a patient who was seen in one of our colposcopy clinics. She was a 35-year-old. She had a history of abnormal PAPs, but she was unsure of the results. Her last Pap smear was 10 years ago. She had a low-grade positive through the health department, and she reported postcoital bleeding with every sexual encounter for the last 6 months. On colposcopy, she had a high-grade CIN2 on her biopsies. She went to LEAP, and the path results came back superficially invasive squamous cell carcinoma. And she had a hysterectomy on April 5th. That says the 4th, but it was the 5th. We got the path back yesterday from the hysterectomy, and she had a 1.5 centimeter mass in her cervix, and you can see that that is not visible in this picture. We must be aware of the risk for cervical cancer in every patient and at all times. One of the most common cytologies preceding a diagnosis of cervical cancer is ascus, and we see a lot of ascus in our patients. Also, if you have a patient who has repeat inflammatory cytology that has been treated and the PAP still comes back inflammatory or reactive, keep that in mind, that it could be something going on that we're not seeing with the naked eye. Also, an unsat PAP. Consecutive unsat PAPs could indicate that there's underlying disease. We must use all of our information to ensure that cervical cancer is not missed. Any presenting complaint, the PAP, the colposcopy, our exam, all needs to go together to ensure that our patients are getting adequate care. Another high alert situation is if you have a high-grade PAP and a low-grade or benign colposcopy. Something just doesn't add up and further evaluation is needed. That's why we consult on these, because proper management is imperative to the care of these women. Most women will see, or most clinicians will see very few, if any, frank cervical cancers in their career. It's important to be aware of the signs and symptoms and the cytology or cytologic abnormalities that could indicate cervical cancer. The next thing we need to do to help prevent cervical cancer is recognize the cause of the problem. You take the good, you take the bad, you take them both, and there you have the facts of life. 50% of all adolescents over the age of 15 report being sexually active, and those who do not admit to having sexual intercourse have had some type of genital contact. And the majority of adolescents with an STD do not know that they're infected, so they're not doing anything to prevent the spread of infections. They also have very short-term sexual relationships, average about 15 months. Some may be less than 4 months, and they're having sex within the first 2 months of being with someone else. I'm going to do these two slides in a different order. HPV is very common. So why does adolescent sex have to do with cervical cancer when we see cervical cancer in women who are older? HPV is very common. 80% of individuals will be infected at some time in their lives, and most infections occur between the ages of 15 and 25. Hang on, I went the wrong way. HPV is spread from direct contact or skin contact, and sex provides a highly effective mode of direct contact. Intercourse, outer course being genital contact that is non-penetrating, touching with the hands, oral sex. 23% of virgins report having had oral sex at some point, and 15.3% of virgins acquired HPV infection prior to initiating sexual intercourse. So contact leads to HPV spread and infection, and persistent infection leads to cancer. HPV is present in 95% of all cervical cancers. Most HPV infections are transient and cleared within 24 months. However, we have no way of knowing which ones of these are going to be cleared and which ones are going to progress to cancer. We know that the HPV vaccine is most effective when given prior to exposure. Since the HPV vaccine was started being used in 2006, studies are already showing that there's a decrease in CIN and genital warts related to the use of the HPV vaccine. Once we realize the cause, we will see the need to assess the HPV vaccination status of all of our patients. So this is where I'm really getting to the meat of what I'm going to talk about, or what I'm talking about today. Here are the top 5 reasons parents gave for not vaccinating their adolescents. It's broken down by males and females, but they're all the same, just they're in different orders depending on the sex. And lack of knowledge, not needed, safety, not recommended, and not sexually active were all the top 5 reasons, whether male or female, why parents didn't vaccinate their children. These are percentages of the adolescents receiving the HPV vaccine. On the left, you can see the United States. On the right is Alabama. It's broken down by males and females, and who have received at least 1 dose or are completely up to date and have completed the series. The United States is around 54% and Alabama is around 47%. You can see that Alabama is slightly behind the rate for the United States, and boys are slightly behind girls, but boys are starting to catch up. And if you look in research and you start looking at studies, there are some countries, other countries like Australia, who are around 75%. And one thing I read said that they even think that they will eradicate genital warts in the next 20 years because of their vaccination rates. The purpose of this slide is to just show you the Healthy People 2020 goal for the HPV vaccination, and the goal is set at 80%. So you can see that Alabama and the United States are way behind, are way less than the goal of 80%. This slide shows the percentage of missed HPV vaccination opportunities by county for Alabama. These percentages were calculated by taking the number of Tdap vaccinations and subtracting the number of HPV vaccinations to show the missed opportunities. The darker the color, the more missed opportunities to give the HPV vaccine. And then on the left, you can see Alabama is at 94% for the Tdap vaccination. So 94% of the adolescents at 11 to 12 are getting the Tdap vaccine, but only 47% are getting HPV. So access is not a problem. You know, they're getting the Tdap, they should be getting the HPV vaccine. So Alabama is 41st and 42nd in the initiation of the HPV vaccine or the vaccination completion, and that is not where we want to be. One of the main reasons cited for not taking the vaccine was that it was not offered. So at each visit, we need to ask about the vaccination status, and if it's not complete, offer the vaccine. In 2019, Title X awarded us a grant to use to help increase the HPV vaccination rates in Alabama. The vaccines were available at that time in only 13 counties, and in 2020 they became available in all the clinics. So who can get the vaccine? It's available to males or females ages 11 to 45, all patients, all clinics, insured, uninsured, but if they qualify for VFC, that should be used. It's available at no cost to the patient, and clinics can also complete a field voucher to be reimbursed for the $8 administration fee. One of the first steps to increasing the HPV vaccine success is developing an appreciation for the high HPV vaccination rates. We must realize by boosting HPV vaccination rates that we are helping prevent cancer. We have to acknowledge the influence that our recommendation as providers has with parents or patients when they're considering getting the vaccines. Clinician recommendation is the #1 reason parents or patients decided to receive the vaccine. Another way to increase the HPV vaccine uptake is to offer it when they're there for other vaccines, and offer it in the same way that you offer other vaccines. And this is a good practice to adopt all throughout the clinic, whether it's in family planning, if it's in immunization, if it's STD. Offer it the same way every time. All staff members need to be aware of the importance of the HPV vaccine and prepared to provide information as needed. And then provide your personal experience or examples. If someone asks me what I think about the HPV vaccine, I always start with, my children are both vaccinated, my son and my daughter. And so that tells them that I believe the vaccine is safe and that it is effective and that it needs to be given. And we all know that perspective is everything in certain situations. So when you're counseling a patient, be sure to provide information that puts the risk of HPV-related disease in perspective to other diseases for which people are receiving vaccines. People are 20 times more likely to die of HPV-related cancer than the other 4 diseases that we're vaccinated for. When the HPV vaccine became available, it was marketed for females and to prevent cervical cancer. Since that time, we've learned that it's related for many more types of cancers, and you can see the numbers on this chart. All of this information needs to be used when you're counseling a patient about receiving the HPV vaccine. HPV related cancers affect men and women, and if you look at the 2 arrows, the number of oropharyngeal cancers has surpassed the number of cervical cancers that occur in the United States annually, and it's 5 times more likely in males than it is in females. This is a slide put out, or a flyer put out by the CDC. Cervical cancer prevention is how the HPV vaccine, like I already said, was first marketed and encouraged. But we now know that that's only the tip of the iceberg. And if the HPV vaccine is given to all 11 and 12-year-olds, it could prevent over 90% of these cancers that we're seeing. One of the big concerns is safety with the HPV vaccine, but it's being used in many countries, and there's substantial data to support the safety since it was introduced in 2006. The studies, there's data from over 12 years, and it's very reassuring about the safety of the vaccine. But even with the safety data that's out there, there's still concerns surrounding the HPV vaccine, unlike other vaccinations given to the 11 and 12-year-olds or to adolescents. So we need to be able to tell people that, you know, the vaccine is safe. We must provide counseling that educates people that there are no serious safety concerns and the benefits far outweigh the risk. Another concern is that it increases promiscuous behavior in adolescents, and there is no data or no studies that show that patients or that adolescents are more likely to have sex just because they've been vaccinated with the HPV vaccine. When we counsel patients or family or parents about the HPV vaccine, be sure to use language that is inclusive and inviting, relays a message that protection is the best prevention, and that it is cancer prevention. Even though a large percentage of our adolescents are sexually active, avoid sex talk because it's uncomfortable, and uncomfortable situations will work as a deterrent for patients or parents. This is a sample script that you can use. I see that you have not started or completed the HPV vaccine. Getting vaccinated against HPV is easy, and we can do that for you today while you're here for your visit. In the United States, each year, HPV causes over 30,000 cases of cancer. The good news is the HPV vaccine is a safe and effective way to prevent these cancers. The best protection against these cancers is prevention. Is this something that you would like to do today? Stay away from saying it's a sexually transmitted infection. People do not think that they get sexually transmitted diseases. And then this is one that could be used if you have an 11, 12-year-old who's there for their routine immunizations. Now that Sally is 11, she's due today for 3 very important vaccines. The first is to help prevent an infection that causes meningitis, which is rare but potentially deadly. The second is to prevent a very common infection, HPV, that can cause cancer. The third is a tetanus booster, which also helps protect against whooping cough. Do you have any questions? So present it in the same way. Present it with the other immunizations and ask if they have any questions. So here's some take-home points. Assess the HPV vaccination status at each visit. We have HPV available for any visit type in all of the clinics. Provide information that's understandable and puts the risk in perspective. Counsel patients in a way that relay the message that HPV vaccine protects against a virus that causes cancer. Avoid using terms that relate it to sex. And lastly, offer the vaccine. Remember, vaccination rates increase when recommended by a healthcare provider. And this is just one last thing. Offer the vaccine. You know, if we don't offer it, they don't even have the opportunity to tell us no. So assess and offer at each visit. Thank you.
Thank you, Stephanie. Good morning, everyone. And those were some startling statistics that you gave out. 3rd in the nation for new cervical cancers per year. So I think with that information, I think we all know that it was very important that we understand at least the basics of colposcopy. So that we can make sure we're managing our patient appropriately. So with that being said, I'm going to start with the basics of colposcopy. For full disclosure, most of these slides did come from the ASCCP, one of the recent sessions from the colposcopy course, although I did add a few slides when it was pertinent to our practice. So the objective is basically to discuss the components of colposcopy, and then we'll go through the procedure. So we'll start with something that we all know, and that is, what is colposcopy? I'm sure we can all give our definition of colposcopy, but the ASCCP defines it as a real-time, magnified, and illuminated visualization of the uterine cervix and upper vagina, specifically the transformation zone. So the goal is to rule out invasive cancer and identify tissue for biopsy. So we're looking for abnormal areas of tissue so that we can take a colposcopic directed biopsy and make a histologic diagnosis. There are several indications for colposcopy. Of course, the first we're all familiar with, abnormal or inconclusive screening tests. These are our high-grade PAPs, ASK-H, AGUS, persistent HPV, or even persistent unsatisfactory PAPs. Symptoms or signs of cervical cancer, Stephanie went over those. Any abnormal uterine bleeding, postmenopausal bleeding, postcoital bleeding. We also have patients in follow-up, colposcopy 6 months for a previous abnormal, or any suspicious lesion warrants an evaluation with a magnification. So whether you're the one doing the colposcopy or whether you're the one getting the records from the physician that did the colposcopy for your patient, there's some things you need to know about this exam. And the first is, was the colposcopy, was the cervix and the squamocolumnar junction fully visualized or not fully visualized? Remember, follow-up plan of care is based on this information, so it's very important that when we read the procedure note, that we find out this information. Was the colposcopic findings normal or abnormal? Was the ectocervix normal, or was there a dense acetyl white lesion? And of course, you need to know how to most effectively biopsy the lesion if there is one. There's really no absolute contraindication to colposcopy, although we don't do ECCs in pregnancy. Also, you want to treat any infections prior to colposcopy, or basically any procedure, because as you know, we wouldn't want the infection to trek up the endocervical canal into the uterus. Also, like Stephanie mentioned earlier too, sometimes you might see with infection, your cervix may be more friable, and so we already worry or think about bleeding when you do biopsies. The colposcopy procedure can be performed if the menstruation if the flow is light and the patient agrees, but she does need to be warned that once the procedure started, if the flow is heavier or the landmarks can't be identified, such as the squamocolumnar junction, the procedure may have to be aborted and rescheduled. To prepare our patients for colposcopy, we can recommend no douching or intravaginal medications for 24 hours prior to the procedure. Of course, we want to explain the procedure in detail. Obtain informed consent. We do have the family planning colposcopy consent form that covers the procedure, colposcopy. It covers the biopsy, it covers the ECC, endometrial biopsy, and photography. Also, we want to make sure we're giving our patients educational information. We have some really good brochures that we give out, and one of them has Dr. Thomas's direct office number, so if there's any problems, they can contact her directly. And of course, we'll do a pregnancy test if indicated. So let's talk about the objectives of colposcopy. So the first objective is actually just to inspect the entire external genitalia area before you progress to the speculum exam. So as you can see, HPV-related changes can occur anywhere, so you need to look everywhere. Another objective of the colposcopy is to identify the squamocolumnar junction fully or not fully, because we already said the plan of care is going to be based on this information. This cervix provides an excellent example of a fully visualized squamocolumnar junction. You can see the squamous tissue, the smooth pink. You can see the darker red glandular columnar tissue. It's separated by the junction, the squamocolumnar junction. Also, this picture is pointing out the transformation zone, but we'll talk more about that in just a minute. But before we do, let's look at some variations of different squamocolumnar junctions. The location of the squamocolumnar junction in relation to the external os is variable over a woman's lifetime, and it'll depend on her age. It can depend on pregnancy, hormonal status, oral contraceptives. But you can see how as a woman passes from adolescence to her reproductive years to postmenopausal years, how the squamocolumnar junction moves centrally towards the os until it's no longer visible on the ectocervix. So getting back to the transformation zone, what is it and where is it? So the transformation zone is the cervical area between the original squamocolumnar junction and the current squamocolumnar junction. Remember, we said it moves centrally towards the os. So let's take a look at this picture. We see the two histological regions. We see the squamous tissue. We see the columnar separated by the squamocolumnar junction. And the squamocolumnar junction is easily identifiable and fully visible. Now, the transformation zone is not quite that easy to identify. There's really no line to demarcate the original squamocolumnar junction, but there are indicators, as you can see, pointed out to us. So you're looking for the most distal crypt or gland opening or the most distant Nabothean cyst. And once you find that, then you're going to draw your imaginary circle all the way around. And this is your outer margin of the transformation zone. So from this area to this new squamocolumnar junction is the transformation zone. This is really important because this is where HPV infections can induce abnormal changes or malignant changes. Here you notice, again, they're pointing out the squamocolumnar junction, and we're looking, you want to look to see if this is fully visible. Can you trace this all the way around? In this particular case, we can. Also, they're pointing out the transformation zone for us. And if you start at the 12 o'clock area where the arrow is and draw your imaginary circle all the way around, you'll see that there is a lesion in the transformation zone. From about the 5 o'clock to the 7 o'clock area, you'll see a dense white lesion with smooth borders. You also notice that the leading edge of this lesion is at the squamocolumnar junction. So that's where most lesions will appear. So that's why it's so important that you see the squamocolumnar junction. And if you can't, then you can't be sure that there's not a lesion present. So in contrast, here's a cervix that's the squamocolumnar junction is not fully visualized. Although we can see some areas of pink, darker tissue, remember it has to be visualized all the way around to be fully visualized. There are some techniques that we can use to try to help us fully visualize either a lesion fully or the squamocolumnar junction fully. And here you'll see a large acetyl white lesion that is dipping into the endocervical canal, and we're using a moistened Q-tip to try to visualize this fully. Also, you can use the endocervical speculum. You can see how it opens up gently and helps to visualize the squamocolumnar junction. Another objective of the colposcopy is to identify, is there a acetyl white lesion? So after the application of acetic acid, 3 to 5%, or vinegar type solution, that tends to make abnormal areas turn white. Also, it helps to dry out mucus and helps you identify the squamocolumnar junction. So if there is any acetyl white lesions, there's some things you need to know about it. You need to know the size and the location, the color, the contour, the border, any vascular changes. All of this information is going to add up to give us our clinical impression. Is this a high-grade lesion? Is this a low-grade lesion? And help us determine where we want to biopsy. So there's different variations of acetyl whiteness. You can see there could be acetyl whiteness at the os. It could be distant, like a satellite acetyl whiteness. There could be a large acetyl white lesion with different densities in each lesion. So you could have a lesion that has low-grade properties and high-grade properties. Or there could just be multiple acetyl white lesions. Another objective of the colposcopy is to identify and biopsy appropriately. Now this cervix does look a little bit different, and that's because it has been stained with Lugol's iodine solution. And Lugol's causes normal tissue to take up a brown color, and the precancer or cancerous lesions do not take up that color. The biopsy should be done at the squamocolumnar junction, at the closest to the squamocolumnar junction. You should do, if it's a large lesion, multiple biopsies. So you just want to make sure that you're getting a good biopsy. This is a biopsy site at 9 o'clock and 12 o'clock. You can see, so it's not just like a little superficial biopsy. It is a pretty good biopsy. So we've talked about how to prepare the patient, we talked about the indications, we've talked about most of the objectives of the colposcopy. So let's put it all together and go through the procedure. So remember, you got all your equipment ready in your rooms, all your solutions, you have your patient ready, you know her history, you know her pregnancy test results, any complaints she has, and you've got informed consent. So remember, colposcopy findings are neither site nor location specific, so you have to look everywhere. So a thorough external genitalia exam is warranted. And then with the speculum, you may want to think about using a speculum a little bit larger than you would typically use for a pap smear, because not only do you want to see the cervix fully, you want to see the upper vagina as well. So there are techniques, sometimes, as I'm sure you've seen in your practice, how the vaginal walls tend to fall in. They're showing us that we can use a condom on the speculum to help hold the walls out. There is also a lateral vaginal wall retractor that you can use, but it's important that you see the cervix fully. I thought this was a really good picture. The cervix on the left is the same, but the cervix on the left, you can see, it looks like you see the entire cervix. You get a good visualization of the SCJ. You could do a pap smear on the cervix with no problems. But as you see, if you open the speculum a little bit wider, now you really get a better visualization, and you can see the upper vagina as well. Then we're going to start with the acetic acid application, and of course, you want to talk to your patients in terms of vinegar. You don't want to tell them we're about to put some acid on your cervix. That might be a little bit harsh. Then we're going to find the squamocolumnar junction, look for the transformation zone, and then we can use magnification, and we can use the red or green light filter to look for any vascular changes. There's 3 classic patterns associated with dysplasia, and that is a mosaic pattern, which is the tile-like pattern, punctations, which is the red dots, and atypical vessels, which can look like a corkscrew or hairpin. And you may hear this further classified as fine or coarse. So fine mosaic pattern would be more associated with low-grade disease, whereas coarse mosaic pattern would be more associated with high-grade. So this is just another component that you're kind of just putting in your pocket so you can make your colposcopic impression. Next, we're going to do the ECC, where we're going to get the cells from the endocervical canal. This can be done with the endocervical curette, which is typically what's used in the colposcopy clinic, or you can also use the Cyto brush, as you see pictured on the right. Each has the same equal sensitivity and the same inadequate samples, but remember, no ECC in pregnancy. So once you do the ECC with the Cyto brush, you see pictured in the middle, your brush should typically look like this. It should be bloody because remember, we are getting tissue, not just cells. And I want to talk about that for just a minute because I know some of you have already done an ECC in your clinic. If not, you may be asked to do ECC in the future. So just so that we can go over that, you're going to insert your Cyto brush just like you saw where the bristles are not visible. Then you're going to rotate the Cyto brush 360 degrees about 20 to 25 times. Once you get this tissue, you're going to cut the brush off in the LabCorp formalin container. So remember, this is not your pap smear container. This is for tissue, so it has to be the formalin container. So if you know you're going to be doing that, you want to make sure that you make arrangements and get the correct container. You're going to label it with the patient's name, and you're going to make sure you write ECC on the vial so that the pathologist is fully aware that this is an ECC. You're going to tell your patients after the procedure, pelvic rest for 2 weeks, nothing in the vagina. If they have any problems, we want to know about that right away. Any vaginal bleeding or heavy vaginal bleeding, lower abdominal pain, fever, chills. We can recommend the non-steroidal anti-inflammatory drugs for cramping or discomfort. We let our patients know the results are available in about 10 days, and if they have not heard from us, remember they need to contact us. We don't want to ever say no news is good news. The nurse practitioner that obtained the ECC will review the results and discuss it with the collaborating physician to come up with a plan of care, append the note, and notify the patient of the recommendations. After the ECC, we do the biopsy. Remember, that's done at the squamocolumnar junction. And it is kind of debatable. Some people say you can do the biopsy first. Some people say the ECC. So we typically do the ECC and then the biopsy. After the biopsy, we use Monsel's solution to help attain hemostasis. It is important that we tell our patients that you are going to have a coffee grain black discharge for a couple of weeks, and that is completely normal. So finally, the last objective of our colposcopy is to correlate our findings. I think Stephanie talked about this already, but remember, you want to take your pap smear results, you want to take your colposcopy procedure note, you want to know about the SCJ. Was it fully or not fully visualized? Was the lesion fully visualized? What was the impression? And then what is the histology results? So everything should kind of match. So if you have a high-grade pap with a dense acetyl-white lesion and a benign biopsy, that is a big mismatch. So you know you have to figure out what happened. Did I not get a good biopsy? Do I need to call the pathologist? So we want our findings to correlate. Remember, the instruments are very expensive, so you want to take care of them. We don't want to just drop them in the sink because they can become dull. And this slide just summarizes the basics of colposcopy. So I hope this review has helped, and I hope you're excited about the colposcopy project, and I hope you look forward to the expansion of the colposcopy project, hopefully come into a health department near you, because I know your patients are important to you, and you are making a difference every day. Thank you.
Thank you both. That's exciting and great presentations to lay the groundwork. We will go to break, and after the break, about a 15-minute break, I believe, then we will start with our next part of our presentation. Thank you. Welcome back to our program, Striving for Excellence in Women's Health. For the second portion of our program, we're going to have both Neysa Hernandez, Nurse Practitioner Senior, and Krista Hood, Nurse Practitioner Senior. We've heard about HPV vaccine, the basics of colposcopy, Now we're going to merge into putting it all together. So colposcopy and pap smear and follow-up A to Z and the documentation of that. So we look forward to these presentations to conclude our program today. Krista and Neysa, go ahead.
Thank you, Beth. Like Beth said, my name is Krista Hood, and I'm going to be presenting a basic PAP follow-up A to Z. So the objectives of what I'm going to talk about today are going to go over the new ASCCP 2019 guidelines and how we're going to utilize the guidelines in application and with our protocol. And we're just going to go through a basic step-by-step on how follow-up works. I'm not going to go into great detail about phone calls or a first-class letter, certified letter. That's not really what I'm going to get into today. Just a basic overview, because as Dr. Thomas said, we have new nurse practitioners. We have, I'm sure, new nursing staff. We have many nursing staff throughout the state who may not be as familiar with our colposcopy program. So my goal is to just discuss everything that I can think about as far as just the basics of how does this roll out and how does this machine work. So, if I can, okay. So, this was just a cute graphic. When I think of A to Z, as I said, the basics, I see these graphics with a lot of my kids' things, and I just want it to be easy and it's understandable so that you can feel comfortable and confident in how you approach follow-up and patient care you provide. So we're going to just start with a introductory or a basic case study. So I'm presenting it like I would if I wanted to see it written or if I was going to start a consult. So just basic format where I start with a 32-year-old. Grabbed a tube, paratube. I made it easy. There's no prior colpo history. I did add in that she's a smoker, and I did throw in the information about HPV vaccine series because as Stephanie so well discussed, how important it is to know these things as far as going into the colposcopy procedure. And you'll see documentation and discussion as we do the colposcopy that we've discussed the HPV vaccine with the patients as well. So I've listed the pap smear history. So in 2020, pap smear was negative, HPV was negative, and the prior 2 years negative or NILM, and HPV was positive. So the reason I used that history was because I've gotten some questions. We've gotten much better and more comfortable with the use of the app and the website. So, but sometimes it's tricky to decide which clinical situation you would choose. For that scenario where you are not just doing a routine screening, so you're really more managing or you're in a pre-colposcopy surveillance period because we already have this HPV positive history. So I chose the routine visit during pre-colposcopy surveillance. I entered the history, and my confirmation or my recommendation was to use my clinical judgment. So I used that again. Like I said, you could actually still use, I did it both ways with routine screening or pre-colposcopy surveillance. Came out the same, used clinical judgment, but this is an example of a patient who had a previous abnormal that did not she did not go for colposcopy at that time. So we're still pre-colposcopy in the surveillance period. So that is why we chose that situation. So we're going to get into a little bit about the standing order that was released, I would say, in February of 2021. And for that order and for our protocol, we would consult the on-call physician because the information from the ASCCP guidelines was use your clinical judgment. So we don't have a concrete answer on do we refer, do we co-test in a year, 3 years, 5 years, what do we do? So this is an example of a case that I would want to consult my on-call physician about so I can decide on next steps for this patient. So you would consult for any clinical situation without next steps. If you get a recommendation to use your clinical judgment, or if you're just basically uncertain about the management. It could be that you got a recommendation that was clear, but something about the app only knows so much, and you have to use your clinical judgment. You have to use critical thinking to navigate through the situation. So that is also a reason why you may consult. So when the ASCCP guidelines rolled out for the 2019 edition, they used an app and a web-based platform. So I wanted to bring up that we know that with any new or very new to us, somewhat, not complicated, I wouldn't say complicated, but it has a lot of pieces to it. When you use an app, when you have this new development in protocol, we have to evaluate this process. And the way we evaluated how we were going to manage patient care was through the standing order that went out in February. So it is completely normal to get a lot of questions, and it's expected to get a lot of consults and questions about management because, as you know, a lot of our patient care does not fit in a nice little package with a bow on it. So it is completely expected to have to ask your collaborating physician for assistance, and we do that in the way of consultation. So we also had language in there about avoiding inappropriate referrals for colposcopy. As we transitioned to the use of these new guidelines, we wanted to make certain that if we were referring our patients for a procedure with another physician, whether that's UAB, USA, any of the outside local providers, that we were interpreting the guidelines correctly. So that was the basis for our standing order that went out in February. This next slide is just a snippet from our actual protocol in the follow-up chapter, and I'm not going to read the whole thing to you, but I just wanted to highlight a few sentences. In the first paragraph, the last sentence, it says, ADPH has adopted these evidence-based references from the ASCCP guidelines. And that although the guidelines are evidence-based, whenever possible, there are going to be situations where we're going to need further clarification, and consultation is our way to manage that situation. So as an update, as we have gone through a few months of utilizing the app, the website, as we have gotten more comfortable with the consultation process, I'm happy to just tell you that as of the April revisions, which should be in Document Library today, right now, that if the app or the website and ADPH protocol, which our protocol, as we've said in that previous statement, is based on the ASCCP app and web application. If they have the same recommendations for follow-up, then there's no consult that is required for further evaluation. So you may refer for colposcopy without a consult, and you would just continue to consult as indicated based on those previous reasons that we just discussed. So as you notice, there's no way that we can absolutely put everything in protocol. There's no way with the new app, the website, all the many scenarios that could possibly play out. We can't put that on paper. We can't put it in our protocol. So ADPH utilizes the ASCCP guidelines to help guide us. So then, therefore, that if ASCCP says whatever recommendation is given for that situation, that's what we're going to follow. So, again, we can refer to UAB or an outside clinic for colposcopy as indicated by those guidelines, and a consult may or may not be indicated depending on if it's an easily discernible referral for colposcopy. You can proceed with that. If you need further recommendations or clarification, you can, of course, ask through our consult process. All right. So this was just this was the standing order, which, again, not going to read the whole thing to you, but at the very bottom, there is a statement about ADPH will enfold these changes in the next 2021 ADPH scheduled protocol revision update, and that has started today. Sorry, my clicker. Okay. So as we go on to consultation, so when you do need to consult the physician on call, you want to make sure you provide them with the most detailed history that you can give in the most succinct, clear, concise way. So, and everyone has done a really good job with this layout through our new consultation process. I just wanted to give some clarifications, just review it for everyone, just so we make sure we're all on the same page. So you want to lead with my 32-year-old, Gravida 2, Para 2, and then any pertinent history. You do not have to summarize all the history. It's just anything that's pertinent to the physicians making their recommendation for follow-up. You want to list which clinical situation did you utilize, because you may get one recommendation using one situation and another recommendation using the other. So it's always best, so we can track your process, if you tell us I plugged in this clinical situation. Of course, the previous testing, and what is their indication for colposcopy if it's performed. Was it that this test result in 2021 was abnormal, or what? You just need to make sure you list out the information. If they have a history of colposcopy, you want to list out their colposcopy, the histology reports, the pathology reports. They've had treatment. As Dawana discussed, she talked about how very important it is to read and understand the reports that we have. So was the previous colposcopy or treatment, was the SCJ visualized? What was their plan of care? And then make sure to include what the immediate or the 5-year risk assessment was and your plan of care. So this is just an example of that case where I listed using the guidelines and the pre-colposcopy surveillance situation, her PAP history, and you want to make sure as you sum up your consult, your plan of care. And the plan of care that you, like that one said, use your clinical judgment. So if I'm doing a consult, I want to make sure I clearly communicate what I think, we should do for this patient based on the history I have. Are you going to be correct every time? Probably not, and that's okay. That's what we're consulting for. But don't just leave it as an open, what do I do type situation. You always want to, it's always a learning opportunity. You want to make sure that you're on the same page. So I would say if there was some history that I deemed, I think this patient is high risk because maybe she had a leak with positive margins in her past, and the guidelines say from this app to repeat co-test in a year. Well, what if I feel like, this wasn't really fully evaluated? I need to state those things in the consult. So you just have to be clear on what you, how you would like to proceed, and so the physician knows where you're coming from, and if there's any clarification that needs to be done, and of course they're going to make their recommendation, and you will go forward with that for your referral or your next plan of care. I think everyone has done a really good job with assigning the notes. I feel like everybody's pretty comfortable with that, but I just wanted to make sure that, we still, mentioned that you want to assign the note to the physician that you're consulting. I always assign them to myself so that I'll remember to go back and review it off so that I've seen the recommendation. Then as a backup, you send an EHR message to that physician. You don't put any information in the body of the message. You don't want to, and this is a good time just to talk about the EHR message on how it's not appropriate to use the EHR message as a way to communicate between staff members on not really appropriate patient care situations. I think there are times when the EHR message is used almost like we would a text message, going back and forth about patient care. And while some of the messages may be pertaining to patient care, it could be inappropriate language is used where there's blame placed or there's like an error involved in something. And we never want, of course, we never want that. We don't want to document that way in a medical legal document. We want to be as professional as possible in all of our documentation. And the EHR message is sometimes used as a pathway where you can get off track and start a conversation in the patient's note. It's attached to the patient and it's easily seen by anybody. Anybody can go into a note and see your entire conversation about a patient. So you just want to be very mindful of how you communicate and how you project yourself, because these records could be viewed by the patient. I've seen records from UAB recently, which is like their messaging system, and you could see how they were talking to each other through a messaging system that may be similar to what we have. So you always want to be careful how you document, and you want to be professional. So the next part after you've consulted and you're moving on to your colposcopy, your need for a colposcopy referral, you want to add that patient to your district or your county list for your ADPH colposcopy clinic. So like Dr. Thomas had said and Stephanie and Dewana had talked about, our long range, this goal of educating and training nurse practitioners to perform colposcopy in the county health departments. Obviously, the statistics are alarming when you look at the state of Alabama, the cervical cancer incidence, morbidity, mortality rates, and these are our patients who are being diagnosed with cancer, dying from cancer, and so as we have developed a plan for training and to go forward with colposcopy clinics to get these clinics out more statewide. So it is a long-term goal that I'm sure that some people who have been with the health department, nurse practitioners, nurses for a long time have always said we have a need for colposcopy for our patients. We have a need. We know we need to do this for our patients, and it's just such a great time where we're getting there. And I feel like we've gotten there with the IUD project, and now we're able to offer IUDs to our patients. And I don't know that 10 years ago we weren't there. So it's just really amazing to think about all the services we can now offer our patients and how being able to provide colposcopy in our clinics is so helpful to patients, because a lot of our patients may walk to the clinics. They don't have adequate transportation. We know there's financial aspects. We provide the colposcopies free of charge to them. We just want, through this presentation, I just want to make sure that everyone is aware of how the colposcopy clinics, how we get them organized, and to give you a little bit of a background into our process. So the more you're familiar with it, hopefully the more comfortable you'll be as we refer patients to the clinics. So I've added the ASCCP interim guidance for the timing and treatment of procedures that came out last year when there was a lot of discussion on how do you handle abnormal findings during this COVID-19 pandemic. So the first recommendation is for individuals with low-grade disease that it's appropriate to postpone any diagnostic evaluation for up to 6 to 12 months. And then the second bullet, or the second point, is high-grade cervical cancer screening results should be evaluated within 3 months of receipt of that finding. So that gives us a little wiggle room when I say with that first point of 6 to 12 months, because I hear a lot of concerns from staff about when is the next clinic, how do we schedule for clinics, I don't know what to tell the patients. So I've often brought this up with the nursing staff about, well, you want to counsel and educate the patient on the need for colposcopy, but we also know that we have some timing that ASCCP has set out that supports our decision and how we proceed to the clinics. So we want you to be comfortable in putting patients on a list where we can find out what is the need in your area. We don't know if they're sent out to other providers. We don't know the high-risk needs. We don't know the low-risk needs. If you refer them out, it's much harder for us to track those. And I would much rather, feel that I sent them to one of our Colpo clinics where I know we're following guidelines, we're going to have a developed plan of care, and versus sending them out maybe faster to a local provider, but maybe that provider doesn't follow ASCCP guidelines, or the plan of care is not what we would have done for the patient, and you're having to manage that. Knowing that you've referred them out to another provider. So we are trying to grow the program. We're trying to offer it in more locations, but we need patients to be on the list for us to do this. Because again, we can't come to clinics if there's not patients to be seen. So that's why it's really important as we kind of develop this program. So once you have a patient that needs colposcopy, I think it's always helpful. Every district does this process differently. But I felt like with the last colposcopy clinic that we did with the West Central District, they had a rather large list that I triaged out. Here are some, I did it by county because that was easier for me to do. Okay, here are my high grades. So I know how many high-risk patients we have. Here are my patients that maybe are post-colpo or post-LEAP. They're in that follow-up period. Here's patients that maybe had a PAP a year ago. Here's a patient that maybe had a PAP 6 months ago or 2 months ago. So those could actually go to the next colposcopy clinic. Or just, I triaged it out by using those ASCCP guidelines during the pandemic to try to help narrow down who do we need to target if we have a rather large list, and to try to trim that down a little bit. So we can also, Dr. Thomas is always wanting to know, we want to know how many high grades do we have? What is the high risk need? What are the lower risk needs? I don't know that if we don't triage the patient. So this was just a way that we set up totals so I could say easily, I have 15 higher risk patients. It doesn't mean that it's a high grade PAP. It could have been an AGC PAP. It could have been positive margins on a past LEAP. It could be a lot of different things. But trying to triage out so you know what you have and you know where to head when you are given a date for your colposcopy clinic. So this is just an example of how I think it's helpful to include a little more information on your list, not only just the patient's name, EHR number, date of birth, insurance, however you're keeping your list. That you don't have to write the whole history on your list, but I think it will be easier going forward if more information is included. So if you have a patient that maybe is post-LEAP and she's due a colpo and ECC, that you make sure you're clear about when that was due, so we can see and not just have a name, because we can see, okay, we're behind doing this, or we have time to do this, and it kind of helps gauge where we are for colposcopy clinics. We're not traveling just for high grade clinics anymore, so I don't want that to be confused. We're traveling for all the patient needs, but we did last year we tried to target the high grade, but we still want to prioritize and make sure that we contact those patients who are at the highest need, the highest risk for SIN3 or cervical cancer, and we try to get those patients to this clinic. So then as we progress, you've gotten we've asked for your list, we know how many are on it, we know that there's a need in your area, your district, your county. Then we do the nurse practitioner seniors, and if there are nurse practitioners involved, we do what we call colposcopy workups. And this is a way for us to kind of evaluate the case, make sure first that there is an indication for colposcopy, that the patient really does need colposcopy before they get there, and they might not have needed it. We could have done a co-test in a year. So this gives us a way to evaluate that. We want to evaluate were they treated for an infection in a timely manner, because if they're still positive and they're on that list, they haven't gotten treatment. I think, as DeWanna said, we would defer the colposcopy. They do not have to be on a method, but we need to be able to rule out pregnancy to do an ECC. So we often list their method of contraception, HPV status, those kind of things in our workups, so that when we are in clinic, we use those to help develop our HPI, so we do not have to dig through the record that day, because we typically have very large clinics. So as most of you know, digging through sometimes the EHR, the documents, the charts, it takes a lot of time. So we do that on the front end. So I want to talk a little bit about how documentation of the history, so that can be made easier. So we have talked before when EHR rolled out about suggestions for how to document things. Well, and as things have gone and we have learned more, we want to change things. So this is an example of how a pap smear history could be documented, that could be used when you're consulting, when you're doing colpo workups. And it's already there for you. We want it to be easier, so you have to set yourself up for it to be easier. So previously, we were listing the pap smear history in the procedure or test section of the medical history. We have found that if you open the hospitalization tab, there's a large comment box that can be edited, that can be rearranged, the dates. So as you might have noticed, if you put it in procedure and test, if you needed to add records you've gotten in, it's not going to be in an order that's easy to follow. So you could start with pap smear history. Reverse chronological order is the way I would recommend documenting, with your most recent result first and then going from there. Because by the time, if you list 10 years of abnormal history, sometimes we lose the point by the time we get to the current problem, and some of it won't change our management plan. So we want to lead with the most recent information. This is an example of how someone used the hospitalization tab, and they used chronological order. So, we have to read through the LEAP, the low grade, and you have to do this as you're taking care of your patient before you get to the 2020 colposcopy ECC benign. So, my eyes would, it's easier to read in reverse chronological order. This is, again, an example of a chronological order chart. So I'm just giving you different examples of how people have documented. The hospitalization tab has been, and it carries to the next annual. So the good thing is you don't have to type any of this. This is not free texting in the chart. This is going to carry to your next history. But if you go in and add your most recent abnormal pap, your history as you get it from your LEAP records or your colpo records, you can add that in medical history and just keep a running list, which will make it easier. Next year, it makes it easier when we're doing colposcopy, because it can be used and attached in if you're appending the note for a colposcopy consult or if you're doing the colposcopy workups. So again, this was how someone went in under diseases in the medical history, and they just chose abnormal pap. The reason they did this is if you don't choose anything in your medical history, you can't choose unremarkable or you can't document. But if you they chose abnormal pap and they didn't add anything under procedures or tests, they just went on to do hospitalization. So my eye immediately caught they have a pap history before they listed all the pap information. So I would recommend, we would recommend avoiding using the procedure or test column where you add in one by one different procedures, colposcopy, the LEAPs, where you have to add more information that looks similar to this, which is harder to follow. It would be easier to document under the hospitalization tab and then continue on that documentation. So next I want to talk about the colposcopy note. So Dewana did a great job of talking about the procedure in itself. So in the last pages of our follow-up protocol, we have a very standardized message that you use when we append the note. So we have done the colposcopy, and we tell the patient, as Dewana said, we counsel in 7 to 10 days. We'll be getting in touch with you with your results. Most of the time, if you're in that clinic and you're waiting for results, you might get the results before we even see them and have time to talk to Dr. Thomas. But the results are already in the lab portion of our EHR. So we will review the records, and then we'll get with Dr. Thomas on next steps and recommendations. Some are straightforward. We know that we're going to co-test a year or refer Philippe. Some require additional maybe P16 staining, and that will take longer for us to get back results. So we will append the note with a pretty standardized script on how we're going to handle it, and then we will assign the note to that person that's going to be doing the follow-up, that's going to be contacting the patient, that is directly involved in that patient care. And they will be carrying out the additional legs, the phone call, the first class letter, the certified letter to make sure the patient is aware of her results, what are the next steps, and then this note will be assigned to Dr. Thomas so we can sign it off. This is all done on the colposcopy note from the day of service of that colposcopy. And we want to use this note as our chain for documentation on anything related to her pap smear history colposcopy, and we want to keep the documentation open and flowing and try to avoid any gaps in care on the note. We know that there's a lot of documentation that goes on in the referral about the specifics on the follow-up steps, but we want to make sure that we collaborate with our physicians and they're updated as we progress through follow-up. This is just another example of the notes, how we've appended the note, assigned it to the nurse, and then the nurse has educated the patient based on those findings. The nurse has assigned it to Dr. Thomas, and she has signed off on it. So then we want you to also be aware of additional places that we document. The EVA note or our colposcope, the notes, the pictures are attached to that colposcopy note in the attachments portion below the banner. It's also in the document manager. We name it EVA colposcopy note. And I feel like it's very clear how we've named it and we've attached it there. So it's all on the one note, but you could find that in the document manager as well. We use these, we'll open them if we're repeating a colposcopy in 6 months, or if we need to see, because we have now gotten to a point in our colpo project where we're seeing patients for their second or maybe third colposcopy, and we can bring up their way their cervix looked and now how their cervix looks and compare in real time with that patient in the middle of the colposcopy. And this is just how we have named the record that you'll see that, and you can open it. And the documentation is the same as the EHR note that Dr. Thomas has used to document her findings, but it has the pictures of the actual procedure. So we want to close the loop, and I think that this is really important. As I said, that we started in 2019, now we've gotten a 1-year co-test, or we've gotten through LEAP, and we've gotten those findings. So there's been time and more testing that has gone on. So we want to make sure that it is appropriately documented. So this is an example of a note that there's been a lot of information relayed, and it's the same colposcopy note. Maybe the patient needed further follow-up, or we're not able to get them in for follow-up, and there looks like we've lost the patient. We want to make sure we clearly communicate to Dr. Thomas that, and we're making sure we don't have large gaps in care. We know, again, that a lot of information is on the referral. So a lot of times we'll say see EHR details for further information, or CEHR for further details, but we've summed up the case so that you know where we're going and what our plan is, and it's all on that note instead, and it's all kept in that one place, and it's also able to be signed off by the physician. And I thought it was a good time to just talk through one algorithm that, since we've talked about patients who have gone for LEAP and we're doing follow-up care for them. So on the LEAP algorithm, it says after a diagnostic excisional procedure. So this is a patient who had a high-grade histology, and the colpo, you could read, as Dewana talked about, visualization of SCJ versus not being able to visualize SCJ. It's very important. So there's different arms for your colposcopy findings. So after your procedure, you do a HPV-based testing at 6 months for, so that would be like HPV-based testing, co-testing in 6 months. So you would want to repeat that. Say the patient had a LEAP in January of this year. 6 months would be July. And then you would go from there, and then the next year would be July of 2022, then July of 2023. So you would have actually 3 testing that would be done, 3 total tests, and then you would go to every 3 years for at least the next 25 years. So you would do have your LEAP date, 6 months later, co-testing, then a year from that, and you would have your follow-up done. So just 3 consecutive co-tests done before you progress to a 3-year follow-up period. And so I think it's also very important just to read the little boxes. The gray box is really important. It's got a lot of good information about post-LEAP follow-up and why you'll see recommendations for a PAP, ECC, colpo in 6 months, or why you would see further recommendations, and it's all based on these guidelines. So I think as we talked about, we're heading in a new direction. We're heading to better patient care of our patients, to be able to better serve our patients, to be able to hopefully improve those statistics about cervical cancer for the women in the state of Alabama. And everybody's a part of this journey. We need your input. We need your actions. We need your follow-up care. And it takes all of us to make this work. As Dr. Thomas mentioned, there's a lot of people involved in this machine. So we really appreciate all you do, and we just want to encourage you to reach out to us if you have any questions or concerns, and we'll hopefully see you in colposcopy clinic. Thank you. And I will now transition and let Ms. Nasa Hernandez take over.
Thank you, ma'am. Good morning. I would like to start by saying that several PAP and breast follow-up audits have been conducted throughout the state. And in doing so, a huge disconnect has been found. And we noticed that things have been done different district by district. So with that said, the first objective of my presentation today is to standardize the practice of follow-up and documentation. And I also will be talking just a little bit about the abnormal breast template. First, I would like to start with documentation. Why is documentation so important, and what is the purpose of documentation? First of all, documentation is to tell the complete story of the patient. Complete, strong documentation is essential, and it's needed not only when we have abnormal findings or abnormal results, but it's needed at all times. We need good documentation for good clinical communication, and also for continuity of care of our patients. Remember, when you document, you're going to have some coworkers that are going to come behind you, and they're going to be reading your documentation. So it's very important that you document exactly what happened between you and that patient on any specific visit. It will help tremendously for your coworker to know exactly what happened on that visit, especially if a patient comes in for a follow-up visit. Let's say that nurse practitioner treated a patient for PID. She comes back 3 days later. So this nurse practitioner is going to look at your notes to know exactly what happened on that particular day, to know if the patient is doing better today or not. Also, outside providers can read your documentation, and lawyers. And with that said, that brings me to the last point here. A good, strong documentation serves as a defense against malpractice or a lawsuit. Some studies have shown that lawsuits will originate most of the time 12 to 18 months after the visit. So with that said, if you do not have strong documentation and that ever happens to you, that's all you're going to have is to review that visit to know exactly what happens on that day. So it better be good documentation. April the 5th, which was just a few days ago, a new U.S. law was passed, and that requires now that healthcare organizations provide patients with free, full, and immediate electronic access to their doctor clinical notes, as well as test results and reports from pathology and imaging. So what does that mean? Even though right now our patients only have small access to their EHR records, that may change in the future. So make sure that you do document exactly what happened on that particular visit, and do not document any elements that were not part of the visit. So remember, documentation, in my opinion, documentation is the evidence of whatever happened between you and that patient on any specific visit. So make sure that you paint the best picture that you can paint at each visit. So let's talk a little bit about follow-up and the importance of follow-up. And I know nurse practitioners, many of you are probably thinking, well, I don't need to know this follow-up process because I do have a follow-up nurse. And that is true. And the follow-up nurse is doing this for you. However, as the highest provider, and because you are the person that ordered the test or any procedures, you are responsible for following up and make sure that these patients were taken care of. Failure to follow up on lab results has been identified as one of the leading causes of lawsuits in clinical settings. Courts have held that providers are responsible for contacting the patient about labs, imaging, and any referral results. When us as providers fail to follow up, it can result in an adverse patient outcome or a liability for us as providers due to a delayed or misdiagnosis or treatment. So it is very important that you start tracking these patients on the day of the visit. Talk to your patient. Let them know what to expect. Let them know when to expect those results. Usually I tell them 7 to 10 days for the results, and somebody will be contacting you when we get these results. However, I put the responsibility on them as well. I tell them, if you do not hear from us, make sure you give us a call and find out if somebody looked at those results already, because it is their responsibility as well. So how are we going to follow up these patients? Well, you all know that we do have a tracking system in place. It's the Tickler system, and it is a safety mechanism to prevent patients from falling through the cracks. So having this system in place will ensure that patients are receiving accurate evidence-based information and that they're receiving this in a timely manner. The Tickler system also ensures that a patient has a proper plan of care in place. It also makes sure that these patients are keeping their follow-up appointments, and also that we receive those records from the outside providers, and those records are received and reviewed. So that Tickler system, we know it's a manual system, it's a Tickler card. In addition, you can create an electronic task, but that only will be in addition. That will not replace the Tickler card. So make sure that you do open a Tickler card once you get the abnormal results. At the same time, you know you're going to open a referral note. Referral note is when you're going to document all the steps taken to counsel this patient, follow-up appointments and results, and so on. Make sure that your documentation is prompt, complete, and accurate. And this is where it's so important that we all do things exactly the same way. We know that our patients now, especially with the electronic record, they go visit different clinics. So make sure that you document exactly in the same place so everybody knows exactly where to look for. So if a patient goes to Lee County, for example, with the hubs and spokes in East Central, she can have an exam done in Lee County and then go to Russell County for follow-up visits. So let's say that the nurse in Lee County has been trying to contact this patient because she had an abnormal Pap. She has not been able to, so she can flag that chart, and the nurse in Russell County knows exactly where to look to make sure that this patient was counseled or not. And if she wasn't, then she can counsel and document. Okay, this is a list of some trackable information. Of course, it is not all inclusive. So things such as a Pap test, colposcopy, any mammogram results, and the recommended follow-up is trackable. Any labs or radiology studies that you order, any pathology reports from colposcopies or breast biopsies, and any referral to other providers. All this is trackable. And make sure that, again, if you order this, make sure that it's done. Put yourself in the patient's place, okay? Would you like to go to the doctor, have them done a test on you and not follow up on the results? I don't think so. So just make sure that these patients are taken care of. So this is straight from the protocol, and you are very familiar with this, but these are the follow-up steps taken and the patient notification process. As soon as you receive an abnormal lab results or an abnormal Pap, the nurse and the nurse practitioner will review these. Immediately, a tickler card will be initiated and also the progress note. Don't forget that progress note in the referral section. I want you to look at the referral as your old CHR-10 or your progress note. This is where you're going to document all the steps taken. And once you do this, make sure that the nurse practitioner reviews this and she or he agree with the plan of care. Once you get the results, you have 5 to 7 days to begin the notification process, and you can either give this patient a phone call or send a first-class letter. If she does not reply within 2 weeks, then you need to send a second notification, and this will be a certified letter. And make sure that every abnormal findings that require a referral or a repeat Pap will require this two-step process. This is also straight from the protocol. On the left side is talking about the ABC program. So if you have any abnormal findings such as a clinical breast exam, a mammogram result, or an ultrasound, you have 30 to 45 days to complete the process. And this process includes the abnormal breast template consult as well. On the right side, we're talking about the cervical. If you have any suspicious cervical lesion on exam, if you have an abnormal Pap smear result, or if you have post-colposcopy results, you have 30 days to complete this process. And that means from the time you receive the results and all the steps necessary to counsel this patient. This is not working. There we go. Okay, so this here, all these abnormal findings will require this two-step letter process. On the first example, if you need a 12-month follow-up, 25 years old with an ASCUS, 23 years old with an ASCUS Pap, she needs to come back in a year. You need to complete the two-step letter process. You need to counsel this patient on this abnormal result. If it is a post-colposcopy follow-up or a post-LEEP follow-up, you need to contact this patient the same way. Any unsatisfactory Pap or quantity not sufficient HPV needs to be notified. And if you have a 35 years old with an ASCUS HPV negative that needs a co-test in 3 years, this lady needs to be notified as well. She needs to know what the results are and the recommendation. If you send the patient for any diagnostic mammogram or any colposcopies and she does not keep the appointment, you need to complete the same process. And if the patient chooses to make her own appointment for a colposcopy, you need to follow up on her as well and make sure she did follow up as recommended. Okay, so let's say that you were successful and you received an abnormal Pap result. You were able to counsel this patient. So now this is the documentation part. Need to document who was counseled. Did you talk to the patient or did you talk to the guardian? How did you counsel this patient? Was it a phone call or was the patient present in the clinic? Make sure that you describe the abnormal findings, exactly what the results were and what the recommendation. And make sure you document also the consequences for not following up the recommendation. Now, when you document about the consequences of not following up the recommendations, it is important that you understand what the results mean. Do you know the difference between a low-grade or a high-grade PAP? Are you going to counsel a low-grade PAP the same way you counsel a patient with a high-grade PAP? No. One size does not fit all. So you need to understand exactly what the results mean. I like to use a scale of 0 to 5 when I counsel my patients. Usually I said 0 is a normal PAP, a 5 is a highly abnormal PAP. So yours is a low grade. So yours is on the left side of the spectrum. It's like a 1 or a 2, okay? I'm not going to tell this patient that if she does not go to colposcopy, she's going to die. Cervical cancer is a type of cancer that progresses very slowly. It's not going to happen from one year to the next, okay? So make sure that you explain this to the patients. Most of the time, cervical cancer develops because of lack of follow-up, because patients do not follow up as recommended. But make sure you explain this to them. However, if this patient has a high-grade PAP, she's on the right side of the spectrum, so it is important that you stress to this lady that yes, she has a high grade, it is not cancer, but it can progress to cancer rapidly if she does not follow up as recommended. And at that time, it is okay to document that you know what, if you develop cervical cancer, you can die. So what if the patient, you're not successful on your attempts when you're trying to counsel this patient with an abnormal PAP? Then you can place this patient, you make sure you completed the process, your two-step letter process. You can place this patient in inactive status at that time. You can make a note, like chart to remain open or inactive. You can flag the chart, and when this patient comes back to the clinic, you're going to counsel this patient at each visit. Now, on the other hand, if you get a patient that after you counsel her, she does not want to go through the colposcopy and she signs the declination form, then that's about it. However, I would like for you to find out why she does not want to go through colposcopy. There's a financial reason. Sometimes they cannot go to UAB, they don't have the money for gas, they don't have the money to pay. So just make sure you find out why, because right now, because of us doing colposcopy clinics, these patients can be scheduled in one of our clinics and we can take care of these. If the patient had a colposcopy in the past that was very painful and she does not want to go through another one, make sure you ask what is it that she knows about it. What was so hard for her to go through colposcopy the first time, and just try to reassure, explain the process to the lady, and maybe having a better conversation and a better explanation of what a colposcopy is, maybe she will agree on going through colposcopy. And make sure that you do document all this counseling in the progress note or the referral form. So after the patient completes the recommended follow-up, make sure that you look up for those records. Make sure you receive them, review them, and make a disposition, okay? All records should be scanned into the referral form. This is a place where, again, we're trying to standardize the process, so if everybody do things the same way, you should have one referral for this abnormal finding, and on that same referral, all these records that you received should be attached. So that way, when we're looking for a specific record, we don't have to go through all the documents in the document section. And make sure that once you receive these records and these results, that you counsel the patient on these results, and you counsel the patient on the recommendations. And of course, make sure that these recommendations align with the ASCCP guidelines. And these patients will be followed until they return to routine screening, and Krista talked about closing the loop. So this is what that means. And making sure all these steps are done will help us provide better care to our patients. And real quick, I'll go through this because Krista talked about it. What happens when we do a colposcopy at the health department? Well, the nurse practitioner will upload the notes of that colposcopy and those pictures into the EHR. We will look for the results, and once we get the results, we will discuss with Dr. Thomas those results, and we will have a recommendation. And once we get to that point, we will append the note, and we'll assign this note to the follow-up nurse. And this follow-up nurse will be the one responsible to counsel the patient, contact the patient and counsel on the results and the recommendation. And once she does that, she will append that note. And make sure that if this patient's recommendation is to have a lip procedure, that you do have an appointment date and time, and include that in your note as well before you assign that to Dr. Thomas. And this is just an example of a colposcopy note, something that you can use when you document, when you append the note, saying that you did get the colposcopies, that you relay these results and recommendations to the patient. And there's something that it says, see referral section for EHR for details. I would like for you to add that in case one of the collaborating physicians is looking for some information that is not included here, they know to go to the referral form and look for that information. And like I mentioned earlier, make sure you do have an appointment date and time for the lip. Now, unless the care is transferred, the responsibility for the patient care remains with you at all times until it's close to follow-up. You are in charge of communication with the patient, so you need to make sure that everything is coordinated and this patient is being taken care of. And again, if you refer a patient to an outside provider, make sure that this patient kept the appointment, make sure that you received those records and that you reviewed them, and that there is a plan of care in place. Right here, this says, I do not understand. Every day the news brings us catastrophe after catastrophe, and yet you're always so happy. What's the secret? It says, I don't watch the news. So just because the guy does not watch the news does not mean that nothing is happening out there in the world. So just because our patients do not hear from us, that doesn't mean that everything is okay. So like it was mentioned earlier, don't tell a patient no news is good news, because that's not always the case. Just because you do not receive a call doesn't mean everything was normal. And just let's talk a little bit now about the breast template. And I'm not gonna spend much time on this because Krista has done a very good presentation in the past, which is available on demand. You can go back and watch it if you need to. But the breast template is just an electronic consult template for abnormal breast followed up. It mirrored after the doctor-nurse consultation that we used to have in place. And they have said that we have a faster response for follow-up nurses, nurse practitioners from the collaborating physician using this breast template. How and when are we going to use this? Well, we will originate a consult for any new breast mass, any abnormal breast exams, or any abnormal imaging that warrants collaborating physician follow-up. And this may include any follow-up cases when the patient returns for the annual exam and the clinical breast exam. And don't forget, you have 30 to 45 days to complete the process and to complete the breast template. And this right here is the way it should look. If you have access, and all the follow-up nurses and nurse practitioners should have access to this breast template. If you don't, just talk to Thelma McDade and she will help you, but you should have it, and it should look, you should have an icon that looks like this on your Lotus Notes workspace. And the form is very self-explanatory. I'm not going to talk about it, but all I want to talk about this is the bottom section of the form. In this form, you need to attach all the documentation received from the outside provider, any results from any mammograms, any screening or diagnostic mammograms, and any surgical consults. Now, few things that I want to mention about this. Before you attach anything to this template, make sure you view the document before you scan it, before you attach it. Make sure it is the right document, and make sure it is exactly what you need to be attaching to this template. Once you attach, make sure you open it. Make sure you read it. If you cannot read it, we're not going to be able to read it either. So make sure that if you're not able to read it, make sure you delete it and attach it again, rescan again. Open the documents after you attach. A lot of times they have blank pages every other page. So make sure you delete those extra blank pages. And if when you open it, the information is cut off, it's crooked or blurry, make sure you attach it again. And once you have all these documents attached, make sure you name them. Make sure you put something in the bottom like screening mammogram from 3/21/21, or diagnostic, or breast biopsy, or whatever the case might be, because that will help us when we're looking for any specific information. Instead of having to open all 6 documents, we know exactly which one to go to right away. And just continue to talk about breast subject. One quick reminder, and it's about your mammogram voucher, your ABC voucher. When you create this from the EHR, when you generate the voucher, in the left side on the bottom, it will have your name, it will have the health department information, and it will have the health department fax number. It does not have a phone number. So make sure that your name is there and that you type your phone number. A lot of times, the imaging places will need extra orders or will need extra vouchers or have questions about the procedure, and they're going to be calling, and usually who they're going to call is Dr. Thomas, because that's the phone number when in their system. And then Dr. Thomas is going to call Beth, Beth's going to call me, and I'm going to call you. So let's go ahead and put your name, your phone number, that way they can call you if they have any questions. Okay, so just Krista talked about this standing order. I'm not going to talk about this much. The only thing I want to talk about is the last paragraph of the order. It says in the bottom that when a patient wants to go to UAB, we will continue to use the UAB referral form. But it also says that with that referral form, we also need to send the clinical situation for that patient. And that is the summary or confirmation form in the app that comes before the recommendation. So this here is the UAB form that we have been using for years. This has not changed. So on the yellow lines, you have a very small space there to add the patient's PAP history, the last 3 years. If the patients have an extensive history, you can go ahead and continue in the back of the form. But don't forget, when you fax this to UAB, you need to fax front and back of the page. And then along with that, you're going to fax a printout of this confirmation. You can do this 2 different ways. If you are using the app on your phone, you can do a screenshot, email it to yourself, print it out, and then send it with the form. Or you can go to the web page and print it out straight from the web page and send it with the referral form to UAB. And this is the recommendation. You don't have to, but it will be helpful if you go ahead and include the immediate risk of SIM3+ when you send the confirmation form. You can write it down. You don't have to print out this form. And this concludes the presentation. If you have any questions.
So thank you both. Awesome. And this really sets the groundwork for continuing our colposcopy program. And it also really, to me, coins our team approach with the nurse and the nurse practitioner working stride and stride, day in and day out. And this will be available on demand. So in other words, we want to use this as our framework going forward as nurse practitioners continue to be trained and clinics continue to be uploaded, if you will, in the process of colposcopy. So we do, I don't see any questions. I'm going to check the iPad. I do have a few questions already. I would just like to say that for today, this concludes our program. And we do thank all of our presenters today, and we have another day tomorrow that we look forward to. I will go to the questions in just a second, but I just wanted to mention just a couple of more things. We had Dr. Joe Reitmeyer on this morning, and I just wanted to say, because Joe has been a longstanding nurse practitioner in our program, that he is taking a promotion. He will be the district clinic director for the East Central District effective tomorrow, and we congratulate you, Joe, in that accomplishment of leadership, and look forward to our ongoing relationship as we continue to serve patients. I want to make sure that there's no questions here. I have a few questions that have come in that I want to address, and I appreciate everyone's question. So I'm going to start back. Our very first question was from Katrina Cuffey from, I believe, Macon and Bullock counties, and thank you for your question. And she was asking, in the Well Woman program, if a client has had their tubes tied or hysterectomy, would we enroll this patient? And I've checked with the program, and we've talked through this, and we don't want to turn patients away. I think that's been a long-going approach that we've had under Dr. Thomas's guidance. So if patients have needs for the Well Woman program in the counties that the Well Woman programs are established, then they can be enrolled even if they've had their tubes tied or have had a hysterectomy. So thank you for that question, Katrina, and I hope that answers that. Yes, Joe?
Katrina said that they're also planning to rediscuss the requirements of eligibility based on residency.
Yeah.
And they're hoping maybe expand that where we could do adjacent counties in the hubs, so to speak.
Yeah. So, you know, the program is definitely growing, and we welcome your ideas about what would work the best. And Joe's point is that it doesn't require the patient to continue the services in the county of location, that can be merged into other counties. So that's an asset to the program, because that's been a bit, you know, of a problem for some of our patients. We had another question around the HPV vaccine, and it was, does a patient need to be enrolled in a program such as STD or family planning to get the vaccine? Or can they just be in the immunization clinic? And the short answer to that is yes. They can just be in the immunization clinic and receive the vaccine. We do not have that requirement just because it came through Title X. The obvious purpose is to help prevent cervical cancer. So any patient that comes through the door, Stephanie made this point well in her presentation, but just to reiterate, any patient that comes through the door that meets the requirements by age, male or female, can get the HPV vaccine. Okay, and then I believe we've had another question from Mandy Seal from the, oh, I'm sorry, it's not letting me in. I've done something that's not letting me in. I'm going to try to remember Mandy's question. And Mandy, call in if I don't get this correctly. But her question was in relation to offering the HPV vaccine as well. And she asked if a patient already had HPV infection, would we still offer the vaccine? And specific, I know Mandy has worked with us in our Colpo clinics, so we do offer the vaccine. As you are well aware, the Gardasil 9 covers 9 separate high-risk strains for cervical cancer. And, you know, I like to sort of make an analogy sometimes with patients around COVID. You know, COVID has variants, and we have vaccine for it now. And you know, we're certainly hopeful that it'll cover them somewhat for the variants. And so the same is true for the HPV vaccine. Even though they have infection, the HPV vaccine still offers potentially some coverage for those types that they may not have come in contact with yet. There was one other question, and I can't pull it up. If you'll call in, for some reason the iPad is not opening up to the password code. So if you'll call in with your other question, if not, then once we collect the questions by email, we'll respond back to those questions today. And then we'll have questions tomorrow. We look forward to our program tomorrow. Will be Dr. Glenn Farr, who's been a long time PharmD that has spoke at our conferences. And then we have a special ending guest as well. Yes, Dr. Thomas?
Just to kind of run things off a little bit regarding the presentations, which I thought were excellent. I just want to quickly thank the nursing staff and the folks out in the districts and county health departments where we do colposcopy. You know, as I mentioned earlier, it takes a team effort, and many of you have embraced this project wholeheartedly, and when we go out to do colposcopy, it's evident by the number of patients that are seen, and just your enthusiasm for what we're doing and that we're bringing this service to your patients. And there's so many stories that I can tell you of the gratitude that our patients express because they can come to the county health department to get this service. So I truly thank you for doing that, for embracing the program. I do want to say that prior to colposcopy being done in the health department, as you guys know, we had to send our patients out, and not all practitioners, if you line 10 of us up, we do things differently. We have different opinions about things, and so you need to be cognizant of that, and you need to follow up, as was mentioned in the presentations, regarding results. So what do you do when something like that happens? When you send someone out for colposcopy and a colpo is not done, right? Or some a plan of care is provided that doesn't jive, it doesn't blend, it doesn't go along with the ASCCP recommendations. You call for a consult, and I think we had a really interesting case of such a happening where, you know, I'm always happy to talk to the patients, and I know the other collaborating physicians are as well, because it is confusing for patients when we send them out and we're telling them one thing and the providers are telling them something else. When I had mentioned my opening remarks, I talked a bit about how things are changing, and they're changing rapidly in this field, and it's hard sometimes to keep up. There's just a lot going on. And so I think that the fact that we have embraced the app, the ASCCP app, and we're working through all of this, I think we're a step ahead of most providers. And ASCCP has a listserv where questions are asked, and the things that you ask and question are no different than other clinicians and providers ask. So, you know, I again will say that, you know, the standard of care that we have for our patients it shouldn't be any different than what we expect when we go to see a provider. And so I think that's where the conversation needs to start, when you have patients who are seen in the health department who are told something otherwise. You can't send a patient, for example, for a high-grade PAP and, for colposcopy if she doesn't get colposcopy. That is just not the accepted standard of care. Now, are there gray areas in between? Sure there are. But for the most part, the guidelines are pretty straightforward. So that if somebody, is sent for colposcopy and for high-grade dysplasia and they don't get colposcopy or biopsies aren't taken, that's something I need to be made aware of. And don't keep sending patients to practitioners or clinicians who don't do what you've asked them to do. I mean, you're referring them because you are unable to provide, the services to the patient. Sometimes our patients decide that they're not going to follow up with us, that they want to follow up with the physicians in the community. And I think one of you mentioned, closing the loop. And I think, I had such a case, and the documentation recently, I think a day or two ago, it was very clear, all the steps that were taken. And I would just go one step further. This patient decided that she wanted to be followed elsewhere. I would make sure that a release of records form is signed by the patient, especially if the patient is coming back into the county health department for care, for birth control. And so to me, that truly closes the loop, because she has signed for her records to be released to someone else, even though that's documented in the chart. It's just kind of an added layer of protection that you've had this patient sign to release the records to someone else. So I think those are sort of protective measures, and I think, closing the loop, so to speak, that we can enact for our patients.
Thank you, Dr. Thomas. We do have a call from Macon County. Macon County, you're on. I'm sorry, for some reason we can't hear that.
We do have a call from Macon County. Macon County, you're on.
Hi, my question was about the EHR generated.
Go ahead.
Can you hear me now?
Yes.
Can you hear me?
Yes.
Hi, my question
It's delayed. Uh-huh.
My question is about the EHR generated mammogram voucher. Is that the preferred form?
That's what we've been using, yes.
Yeah. Are you saying, is that the preferred form over the voucher? Yeah.
This is the old voucher. Yes. I don't know. I don't know if this is the preferred.
Preferred is yeah. I think you actually can use either voucher when you send those to the provider, but I will make sure.
That was my question, yes.
Yeah.
I've never seen the EHR generated one before.
What did she say?
She has not seen the EHR.
Oh, okay, great. Well, great. So that's, what today is about. So, yeah, we'll try to follow up with that tomorrow to make that clear for everyone, and discern around that. So thank you for your question. We have a call from Coleman. Caller, go ahead.
Yes, I had a question. On our patients that receive LEAP, the MD recommends a co-test in 1 year, but the new ASCP-based guidelines recommends a co-test in 6 months. Due to the discrepancy in recommendations, do we need to consult, or can we, as nurse practitioners, just say co-test due in 6 months?
Yeah, that's a great question. So yeah, I think you can say that to the patient based on the ASCCP guidance. And certainly if the patient chooses to have that smear done in the county health department, they can do that. So I think you can certainly make that recommendation. It's as I mentioned earlier, it's hard for folks to keep up with these changes that are that are coming pretty fast and furious. And so again, I think we're doing a pretty good job in caring for our patients and doling out the best possible care. And so I think when we talk with patients, about guidance and follow-up, always keep in mind how you would want to be treated. How would you want, if you're dealing with if you're a parent, you got young folks, young children, or daughters who are post-adolescent, how you would want them to be treated if they went to the county health department, how you'd want your sister treated, your aunt treated. So it's the same kind of thing. You're giving them the best possible evidence-based guidance. And I think that's how we need to treat our patients, exactly how we want to be treated, and no different.
Thank you so much for your questions. I think that's the end of our questions. If you have questions, still continue to send those in through email. This does conclude our program for today. We look forward to our program tomorrow. Thank you for your time and attention. Have a great day.